And welcome to the presentation on mucolytics, antimicrobials, and vaccines. So we're going to get into a lot of stuff in this, so take breaks, make sure that you're writing adequate notes, or if you're not taking notes, that you're just listening to it at a good pace to sort of absorb that material. There's a lot of stuff to cover, so let's get started. So beginning with mucolytics, the big thing is to understand when we're going to be using mucolytics, other things that could help with airway clearance therapy, and then understanding what really mucus is, so there and the different types that goes on with it. So that way we could help better treat a patient that has a lot of mucus problems. So let's get into mucus, first of all, is a gel. And what the whole point of mucus is, it's a protective, lubricating, and waterproofing substance. And so the big point is to entrap microorganisms and to inhibit infections, and it has biofilm formation in it. So if there's anything in the airways, and we're talking specifically about respiratory, if we have anything in the airways that is an infectious agent, the whole point for it is to fill a biofilm around it and to help eat it and to destroy it and to neutralize it, so that way it doesn't cause a bigger infection. So biofilm is a big part, and it's one of the things that you're going to see out there in the research on looking at these patients that have ventilator-associated conditions or ventilator-acquired pneumonias, VAPs, because what happens is biofilm will actually form on the inside of endotracheal tubes or tracheostomy tubes. And then when people go in and instill saline to suction, it washes that biofilm, that thing that's created to eat and to destroy foreign objects. They wash that biofilm down into the airways, and it can cause that pneumonia and all those things that it is trying to protect and isolate. It breaks it apart and allows them to spread throughout the lungs, and that could lead to that infection. So it does have that biofilm capability, and it's a good thing that it has that. However, when we do bad things like instill a bunch of saline down an artificial airway, which we can talk about later, and we probably did talk about this in Intro to Mechanical Ventilation, is not so good when we start messing with the way nature intended things to work. So we do see that it has that biofilm formation, it does entrap microorganisms, and it does inhibit infections with that biofilm. So it's a good thing, right? Mucus isn't a bad thing by any means. It's just the hypersecretion that can potentially cause more harm than benefit that we really have to work on. Mucus does protect against osmotic or inflammatory changes as well. So it's trying to help eliminate or reduce those osmotic or inflammatory changes that can go on in the airway. The next point here is mucolysis, right? This is the thinning of secretions. This is a big one. Mucolysis is one of our goals if we have someone that has thick, sticky secretions. And so allowing us to thin that out might help with airway clearance therapy. It might help avoid mucus plugging. It might help with the patient's ability to ventilate without obstruction. So that's a big goal on these patients that have really thick secretions. The big worry here as well is the over thinning of the secretion. So we just got to be careful about that. That's why whenever you suction, you're going to have to note the consistency of the secretions. Is it highly spinnable and thick and sticky, or is it very thin and watery? If it's very thin and watery, should we be continuing to do mucolytic therapy? Well, that's a discussion both you and the rest of the care team can have. The next one here is mucoactive agent. Any medication or drug that has an effect on mucus secretion would be considered mucoactive, whether it makes it thick and sticky or thin, right? Anything that does anything to the mucus secretion, whether it inhibits it or enhances it, that would be considered a mucoactive agent. So it's a broad umbrella term that we use. And finally, the mucolytic agent. These are medications that degrades polymers in secretions. They degrade the polymers in secretions. So they're there to help destroy the polymers. And then when we're talking about these being under this umbrella term of mucoactive agents, Mucoactive agents can be anything from a mucolytic to an expectorant or a mucokinetic. And mucokinetic will increase their coughing or their ciliary beat, right? It increases that ability to clear those secretions. So a mucolytic agent is part of or under that umbrella of mucoactive agents. So what are some clinical indications? One of the things that we like to do this is to reduce the accumulation of airway secretions. It's not that we don't want to have mucus. It's not that we don't want airway secretions. Like I said, they are very beneficial. What we don't want is the mucus plugging. What we don't want is the obstruction and making it hard for those patients to breathe. So that's the issue that we're having to deal with. How do we tame that down to a level that's manageable for this patient to breathe? The next part here is to improve pulmonary function and gas exchange, and that's going to be the big thing. If we're having a lot of thick, sticky secretions and we're having a hard work of breathing, we're having a respiratory acidosis, we're working hard to breathe, or maybe an alkalosis if it's early on with their mucus issues, then we need to make sure that we can improve that pulmonary function and that gas exchange by helping control that hypersecretion or the consistency, right? The thick or thinness, the consistency of that mucus. And then another indication here would be preventing repeated infections and airway damage. That's going to be one of the ones that we have to look at here as we're going down this list. And some of the big diseases that we're looking at include chronic bronchitis, cystic fibrosis, panbronchiolitis, and bronchiectasis. Now remember, bronchiectasis has two formations. You have non-cystic fibrosis bronchiectasis and cystic fibrosis bronchiectasis. But when we're looking at diffuse panbronchiolitis, just to move up to this one here real quick, that diffuse panbronchiolitis, it is what's known as an idiopathic inflammatory disease. We don't know, but it does cause severe obstructive issues, right? Severe obstructive issues. Because it has that inflammation in there and they create a lot of secretions, it can really inhibit their ability to ventilate, and it can eventually cause airway damage right there, right? So we can even see that airway damage. But understand, not all patients with mucus accumulations will benefit from mucoactive agents. Sometimes it's just something as simple as getting good quality airway clearance therapy that includes a good strong cough or good hydration, good systemic hydration. So not every patient that has thick mucus needs to go on some sort of mucoactive agent, but it is one of those things where we can consider that to help, especially if their secretions are hyperthick. If they do have a condition like cystic fibrosis, bronchiectasis, right, we should be looking at these. The mucociliary system, when you have mucus secretion, and it's lining the surface of the airway. This is what's going on continually, unless for some reason it's been inhibited by some reason or another. So you have that sol and that gel layer, and we talked about this way back in pulmonary A&P. The gel layer is the one that's on the very top, the one that is thicker and sticky, and it's the one that will be able to trap any pathogens. It's the one that will be able to hold any dust or anything that you're breathing in and trap those. It's the thick, sticky part, right? And then underneath that gel layer is the sol layer, which is where all the cilia like to beat. The cilia will beat mostly in that sol layer, and they'll strike the very bottom of the gel layer to move it along, right? The gel layer has to be thick if it's going to trap things. The sol layer is very thin and watery, and it's going to have that ability for the cilia to move through it and allow for that mobility of that gel layer to move up and out of the airway. This is a weak gel. The sol layer is a very weak gel, like I said, because you need the cilia to beat through it. Could you imagine walking through a muddy puddle, right? Walking through mud slows you down, and so it's got to be very thin and watery if we're going to let the cilia move in there. So this is the layer that does contain something called mucins. We're going to talk so much about mucins, right? You're going to get so tired of that word. the mucins will bathe the cilia and separate the gel layer from the epithelial lining. So the mucins are one of the things that we have to look at for helping to thin out secretions if they get too thin. So the mucins in that sole layer, right? And that's what surrounds the cilia. That's that stuff the cilia are beating through, right? And it's the one that separates that gel layer from the epithelium, right? When we're looking at this, the surface epithelial cells are essential secretory structures. Essential secretory structures. So when we're looking at this, the pseudostratified ciliated columnar epithelium cells, this is what I would call PSCC, pseudostratified ciliated columnar epithelium cells, right? This long term, but I just call it PSCC, right? This is the one that contains goblet cells and submucosal glands. Submucosal glands are usually located in that lamina propria, that middle layer there. And the goblet cells, they're about 6,000 per millimeter, right? And they respond to irritants or secretions. So if you have chronic irritation of your airways, let's say it's cigarette smoke or chronically breathing in coal miner's dust or anything like that, you're going to create a ton of mucus. So your goblet cells will actually not only swell and create more mucus, but they'll also proliferate. They'll make more baby goblet cells, and those goblet cells will make more goblet cells, and then you're going to create even more mucus, right? And so you can see that that's a situation where it could eventually lead to a lot of thick, sticky mucus that we can't catch up to and clear. And then finally, you have your Clara cells or your club cells. And we talked about that in pulmonary AMP. They're referred to as club cells traditionally, but Clara is still out there. But the club cells are another secretory structure that will help with irritants and clearing those out. And the club cells are the ones that are located in the respiratory zone. They're located in the alveoli, the alveolar ducts, the alveolar sacs, right? The respiratory bronchioles, right? So the Clara cells, the club cells are located down there. The goblet cells and the PSCC is located in the tracheobronchial tree, so the conducting airways. So here you got things that will help protect, secrete, and help protect against pathogens or dust or anything like that. One of them is in the tracheobronchial tree, the conducting airways, where it's moving the gas in and out or conditioning the gas as it's moving in and out. And the other one is in the respiratory zone as another last-ditch effort to help clear and make sure everything is clean. So submucosal glands, they're found in your cartilaginous airways, right? We just talked about this being the tracheobronchial tree, but they're in the cartilaginous airways, which goes all the way down to the terminal bronchioles. So when we're looking at this, they're your cartilaginous airways, so your conducting zone, and they provide what's called mucin. And mucin, I've already previewed it a little bit there. Mucin is going to be one of the big things that is in that gel and sole layer. It's that primary thing that's in that sole layer. So this one includes parasympathetic or vagal control is the primary driver of the submucosal glands. So the submucosal glands are driven by the parasympathetic stimulation. So remember, your parasympathetic stimulation is your relax and digest. So when we have a sympathetic stimulation going on, we may not have as much secretion, right? We're going to inhibit that ability to do that. So you could have stickier secretion. So if we give someone an Atrovent, a parasympatholytic, right, it's blocking parasympathetic control. And that's going to make where we're going to have less secretions from our submucosal glands, which could lead to things like mucus plugging. There are two types of mucus glands that we are two things that we're looking at is the mucus and serous that are the after production of these. So when we're looking at submucosal glands, it's under parasympathetic or vagal response to cholinergic stimulation. So if we, it will increase the amount of mucus secreted if we have parasympathetic control. But if we switch over to sympathetic control, right? Remember, only one system can be dominant at a time. If we switch over to sympathetic control, that's when our ability to create secretions goes downhill. And that can really impact, it can really impact the thickness of the secretion. So that's something to think about if you're giving people parasympatholytics or sympathomimetics. And if you're like, show me a picture, right? Show me a picture of all the stuff. I'm a visual person. Well, here you go. Here we have the sole and the gel layer. The sole layer right here is the one that has very thin, watery, mucin-filled fluid, and it's striking the very bottom of the thick gel layer up here. So the little hairs of the cilia will strike the very bottom of that gel layer and move it on up and out of the airway. So any dust or pathogens that get stuck in here, right, they just get stuck in that gel layer, and the sole layer has that cilia that'll just beat and move it on up. And then when we're looking at this, here you see your epithelial lining, right? Your lamina propria, and then which includes your bronchial smooth muscle, and then outside and not in this picture is going to be your cartilaginous layer. So here you see the goblet cells, right? This is the goblet cells here, and your submucosal glands. Both of those create the mucus. They're both creating that mucus that we're looking at here. And these are under, I'm circling this down here, is parasympathetic control. Parasympathetic control when we're looking at this. So when we see this, the parasympathetic system will create these granular cells and mucus cells and secrete it. But if we have sympathetic stimulation that's efferent, right, that exits the brain, it can actually inhibit and block that creation of mucus, and then whatever mucus is left over becomes thick and sticky because we're no longer supplying a lot of it. I hope that picture helped you a little bit. Now let's look at the transport of mucus. The mucus is the movement of mucus by beating the cilia. The cilia are an important part to pay attention to here. The cilia are inhibited by a bunch of things, and we talked about this way back in pulmonary A&P. You're like, yeah, I remember every single thing from that class, Derek. Well, maybe, but the cilia can be inhibited or paralyzed by things like cigarette smoke, pollution, positive pressure ventilation, suction, right? Those are a lot of things that I just listed, and it will paralyze the cilia, and it makes them unable to mobilize their secretions. So it's a very significant situation when we don't have adequate ciliary beat. General anesthetics is another thing that will inhibit ciliary motility. Hypoxemia, acidosis, those things will inhibit ciliary activity. So there's a number of things that can do this. Well, why do we give nebulizers to patients after they've been under general anesthesia? Well, one reason is to actually help the ciliary beat, because some of those medications could improve ciliary motility. So there you have ultimately at least 200 cilia per each cell. At least, right, 200 cilia per each cell, and it beats at a rate of 8 to 18 hertz per second. So that's a pretty fast ciliary beat. And when we're looking at this, the next part here is that surfactant layer, and you should have a surfactant layer in your lungs. The things that make the cilia go paralyzed, so most of those will also be included in things that inactivate or stop your type 2 pneumocytes from producing surfactant as well. But that surfactant layer that's in your lungs that help reduces surface tension, that has that DPPC in there to help lubricate and make sure water molecules separate themselves so you don't have high surface tension. That surfactant layer allows the cilia to transport without being tangled. And it also prevents water loss, because what does surfactant do? It separates water molecules. It separates them so they're not too close to each other. So that way we can keep water molecules in. We're not transporting all water molecules out. So that's a pretty decent, smart design for sure. Then now we're looking at these factors. We're looking over here at these factors that affect the transport of cilia. And one of the things that we're looking at here is COPD, cystic fibrosis. What do we know about their secretions? What do we know about their airways? A lot of airway damage and inflammation with those disease processes. Airway drying can easily be an issue. Any types of narcotics that a patient has been under, so post-op general anesthesia surgery, someone's in general pain, narcotics can easily inhibit this. Suctioning, we talked about that with nasotracheal suctioning or endotracheal suctioning. Anything there can inhibit that, and that's if you're using that horrendous activity of deep suctioning. I won't even go on that right now. Things like cigarette smoke, allergens, too much or too little oxygen can easily inhibit the ciliary motility. So let's talk about your normal mucus production. Your normal mucus production, usually you'll make in your lungs 100 mLs for every 24 hours. In your nasal cavity, that's a whole different. That's around 1.1, 1.2 liters a day, right? A lot more up there in that nasal cavity. But when we're talking about the pulmonary system, around 100 mLs for every 24. Most of this water is either reabsorbed into the epithelial lining, or it's when it makes its way up with secretions, it's swallowed, right? But when we're looking at this gel, and when we're looking at the makeup of gel acts like both a solid and a liquid at times. So we got to be very careful with how we're treating these patients with mucoactive medications. Normal lungs, you're going to have very low viscosity and moderate elasticity of secretions, right? So mucus in general should be that clear, very elastic, very sticky, right? Viscoelastic and sticky. There should be mostly water contained in here. The water contained in there is what helps make it thin and what helps it be transported and give it that water content to help it stay nice and clear, nice and thin. And then the last part here is the mucins are the major component of the mucus gel. So what makes this gel the gel? Well, that's the mucins, right? And this is responsible for that protective clearance properties. So you want mucins, right? You don't want to inhibit mucins by any means. You just want to turn it down when the patient has a lot of side effects going on. Mucins, what they do is they form a flexible thread-like strand, so they make it very, very thick in order to help it mobilize. And that movement of the mucus layer is really dependent on the concentration of the mucins. If it becomes too concentrated, then your cilia can't beat, then you can't mobilize those secretions, right? You can't. The primary function of the respiratory tract altogether is, and we're talking about the tracheobronchial tree. Tracheobronchial tree, we're not talking about the respiratory zone, right? We're talking about the tracheobronchial tree. The primary function of the tracheobronchial tree of the respiratory tract is transporting and removing trapped particles, cellular debris, dead and aging cells, dust, you name it, pathogens, right? And so that's that primary function of it. And the volume of secretions can really increase dramatically if there is something like, hey, a pathogen that goes in there, or an increase in cellular debris that the patient has, like they have developed a bacterial pneumonia, right? So you'll see those things there. So are mucins bad things? No. But is too much mucins, can that cause an issue? Yes. And that's what we look at here. So here you see the slides, baseline, and then finally you see the production. So we're going from baseline to production, and then you have production and secretion of that mucus. So you can see how those goblet cells and the submucosal glands are starting to create and fill these little cavities over there, right? Start and create. And then finally, they're creating it, they built it up, and finally we have that secretion, right? It's producing and secreting, and now you see these guys that are empty. And so hopefully they're in that soul in their gel layer, and they're trying to trap and mobilize any debris or aging cells or anything like that that could be in the airway. Sputum versus phlegm, it sounds like a fun movie, but I guess I'm a little biased on that one. But when we're looking at sputum, sputum is technically expectorated phlegm. So that means it's from the mouth. Sputum means from the mouth. I think it's German, that means from the mouth. It's expectorated phlegm, and it's composed of mucus. So when we're looking at sputum, it can be mixed with saliva, and so if someone has an upper respiratory tract infection, a sputum sample in theory could be contaminated with upper respiratory stuff, or even with anything that's in the oral pharynx with saliva. But to get a true sample from what's just in the lungs alone, you would need a tracheal aspirate. And that's where things like suctioning comes in, or bronchoscopy comes in, right, for those. But otherwise, if it's sputum, it means from the mouth, which means it could include saliva, right? When we're looking at the sputum, it's composed of mucus, some inflammatory cells, cellular debris, polymers of DNA. So the polymers of DNA is more significant in cystic fibrosis. It's more in chronic bronchitis. Cystic fibrosis and chronic bronchitis. And this, when you see these polymers of DNA, it's usually more of a pus, right? Cellular debris, right? All right, it's more of a pus. So you see those polymers of DNA, and then you see that pus, right? And pus-like type secretions. And that's why these disease processes, the cystic fibrosis, chronic bronchiectasis, or even the inflammatory mediators that we see in neonates, which can't create mucins quite much, they're going to use a DNA lysing drug like pulmozyme or DNase to help with their secretions, because their secretions are less on the mucin side, so they're not likely to respond to something that breaks apart mucins. They're designed to respond better to something that breaks apart pus, which is that DNA connection that you see there. And then finally, bacteria can easily be a part that's in there as well. Normal clearance is going to be altered by changes in volume, hydration, and composition, and that just happens. Sputum does come through your mouth is the big thing to remember here when we're looking at this. And then chronic bronchitis, when we're looking at this, their daily sputum has to be 3 months, 3 months in a row. Daily sputum production has to be 3 months of daily secretions for 2 years in a row. And with chronic bronchitis, those goblet cells will swell. They'll increase the thickness of the airway wall. The goblet cells will not only increase in production, but they'll increase in size and number, right? They'll proliferate and get bigger to create tons of mucus. And then during exacerbations, that increase in DNA polymers becomes very much like cystic fibrosis. So these patients will respond well to an inhaled medication like DNase or pulmozyme, right? Lots of stuff here. All right, let's talk about plastic bronchitis. This one I previewed before in other courses with you. This is the formation of large gelatinous or rigid airway casts, and this is what we see down here. Do you guys see that one there? It looks like an airway cast, and it's pretty significant. And this is repeating in their airways after airway after airway, just large casts. Their casts are thick, and you're like, well, it seems like they're pretty easy to remove if they're thick. No, it's harder to remove the thick. Not only are they thick, but they're also fragile, so they'll break apart pretty easily. Some of these patients will expectorate these on their own. They will cough up these casts. It's pretty insane. Yes, we can go in bronchoscopy and help, but sometimes they'll just clear it on their own, which is great because one of the side things that can happen with bronchoscopy, A, you're occluding their airway, and B, you're irritating the airway with the scope as well. So do we want to add to their condition with more irritation in their airway, right? We have to look at risk versus benefits there. The big things that can cause plastic bronchitis would be asthma, aspergillosis, a little fungi there, and then finally right middle lobe syndrome, right middle lobe syndrome. And when we're looking at this, treatments should be targeted at the underlying inflammation. So this is where your systemic steroids or inhaled corticosteroids, if they're very prone to this, can become very, very handy. Cystic fibrosis, this is a big one. Cystic fibrosis is characterized by an impaired CFTR protein, an impaired CFTR protein. It makes very little intact mucin, so that makes it hard for them to move secretions. Because remember, mucin is that thin water, that thin water-like substance that's in the sole layer, right? That's in the sole layer versus the gel layer, and you're going to be a lot stickier and thicker mucus that's in there. Also, they're not going to really respond most of the time to medications that thin out mucins. They're going to respond better to things that thin out DNA, right? That pus formation. That's what we're looking at here. So they make very little mucin, and they have that impaired CFTR protein. So that mucus that they do have absorbs a lot more sodium, and that sodium will make the mucus very tenacious and more pus-like, right? We're going to see more cellular debris and more pus-like formation there. That mucus really, when we're seeing it, they're more prone to Pseudomonas and gram-negative infections and inflammation. They'll have that bronchiectasis. Remember, there's two types of bronchiectasis: cystic fibrosis bronchiectasis and non-cystic fibrosis bronchiectasis. So that would be someone that just gets repeated infections without having cystic fibrosis. But these patients will have infection, inflammation. It will form bronchiectasis, which is a necrotizing infection of the airway. And then their pulmonary function values will start to decline. It usually starts off obviously as an obstructive condition, but in severe cases it can also cause a combined effect where they're both restrictive and obstructive down the road, right? And that would be from that repeated scarring of the infections and the respiratory decline from those. When we see this, that mucus does absorb a lot more sodium, and the cells can't release the chloride. The cells just hold on to it. They can't release the chloride, and that's when you see over here, right? The cells cannot release that chloride like they do in this picture over here, right? The cells cannot really release that chloride, which means there's low water content, so which means there's an increased reabsorption of cellular fluid. So you can see this would cause a lot of trouble with these patients and their ability to clear their airway secretions. Let's start off with one of your favorite medications, not one I would recommend for smelling. This medication is shown to not improve mucus clearance, right? For airway clearance therapy, it's been shown not to do this. It is a mucoactive medication, acetylcysteine, or also known as Mucomyst, is mucoactive, but it's designed for direct instillation via bronchoscopy, and that's where it's going to usually be its most effective. Is we see a mucus plug in the airway, it's very thick and sticky, we can't suction it through the scope, then we could instill some acetylcysteine or Mucomyst and directly thin out that secretion. It does not improve mucus clearance. It does have a side effect of bronchospasm. And then the big thing here is understanding that they did studies that looked at COPDers that were nebulized this drug. They were nebulized Mucomyst, they were nebulized acetylcysteine, and their pulmonary function values actually got worse compared to the control group. So this is not a medication you would want to nebulize to someone with COPD. This can be used PO, it can be used by mouth, it can be used IV for other things. So it can be used by mouth for things like a Tylenol overdose, acetaminophen overdose as well. And I've seen them use it to help with IV clearance of things like the contrast that they give patients during a CAT scan to help with renal elimination of that contrast. So this is one of the ones you'll see out there. How does it work, you might ask? And why does it smell like eggs, like that sulfur? Because what it does is it hypersaturates. There's two sulfurs or what's called a disulfide bond with your mucus. And what happens here is the mucins form that disulfide bond, and if they're really thick, it's a very strong bond. What we do here is we hypersaturate that bond. We break it up, if you will. We add someone in there to break that up. And what happens then is that will allow that mucus to thin out when we break up that strong bond. So they're holding hands, right? Playing that old game Red Rover, right? They're holding hands, they have a super strong bond, and we're going to add another sulfur right over and bust that bond, right, to help it release, so it's a lot easier for the mucus to come up and out. So they work on mucins primarily, right? This medication is designed to more work on mucins than it is on pus formation. So if you have someone with cystic fibrosis, they're going to respond more to the DNA or the stuff that breaks apart the DNA, that pus, right, in DNA, right, more than you're going to see that them respond to something like this. Dornase alpha, also known as DNase. So this is one that you'll see out there. This would be on your mucolytic drug table as well, besides acetylcysteine. The big indication for this one is for airway clearance of secretions in cystic fibrosis specifically. However, if we have someone that has a large formation of pus, like a neonate that has lots of mucus, right? They don't have a lot of mucins, so their formation, that thick mucus, is mostly DNA, so they might respond better to DNase or this medication, Dornase alpha. But the primary indication is only for clearance of secretions in cystic fibrosis. How does it work? The mode of action, it reduces cellular DNA and F-actin polymers, so it helps break apart that DNA handhold, that DNA bond, so that way it will thin the mucus. It does reduce viscosity and stickiness of the secretions. It will lyse that DNA polymer, right? It breaks that DNA polymer apart. The big thing that's different from this than acetylcysteine is this one needs to be refrigerated and protected from light. It's very sensitive to those changes. When we nebulize this one's given traditionally via a PARI nebulizer. Now remember, the PARI nebulizer nebulizers at a smaller MMAD, mass medium aerodynamic diameter, than a traditional small volume nebulizer. So that's one of the advantages of that nebulizer, is we can get it deeper into the airways and get it to where most of that pus is forming, where we're having issues there. It is off-label for ICU patients, and it's one of those things that we have to make sure that we're looking at how much the patient might need something like this compared to good systemic hydration. Here you see pictures from your book, both pre and post mucolytic therapy. So here we can see version A and version B. Version A is over here, and then version B is over there. So version B will be on the right side of the screen there. You can see that little letter, and you can see how those particles are just broken apart. We're busting those bonds, those handhold bonds, and allowing that mucus to thin out. So this is them just putting it out there and just showing them being broken apart to hopefully allow for better airway clearance therapy. So what are some side effects of Dornase alpha? Side effects of Dornase alpha include voice alteration, pharyngitis, laryngitis, some chest pain, some conjunctivitis. So we try to avoid it getting into their eyes. Understand that you need to evaluate these patients for things like chest pain. And that's not something we typically evaluate for after regular nebulizer treatments as well. And here you see the PARI neb in use, right? There's the PARI neb that's in use. And then we see laryngitis and pharyngitis in their throats, and then making sure that they're those three here, the voice alteration, pharyngitis, laryngitis, right? These three are other side effects that we have to watch out for as well with this medication. So those are mucolytics. Let's go into expectorants. So expectorants are medications meant to increase the volume or hydration of the airway secretions. Increase the volume or hydration of airway secretions. So if we increase the hydration, that should allow the secretions to be less sticky and hopefully help mobilize more effectively as well. So that's going to be the one big advantages here. One of the first drugs and most common drugs out there you're going to see is a medication called guaifenesin. This one is toxic to cilia if in direct contact with the airway. So should you nebulize guaifenesin? I'm hearing you pay attention right now. Should you nebulize guaifenesin? No, you should not, because it is toxic with direct contact to the cilia. So this is not something we nebulize. It is something that's a tablet, right? It's a PO medication, and it comes in an extended release tablet that anybody can take by mouth. And then this is even an over-the-counter medication that can really help expectorate or clear some of those secretions. So very common. It's a good one to recommend if your patient in the ICU has lots of thick, sticky secretions, or even over the counter for situations where you might need it. It can be very helpful to help clear some of those secretions that might be very tough to move. Hypertonic saline. I am a big fan of hypertonic saline. This is what's known as a mucokinetic medication. Traditionally, you have your 3%, your 5%, and your 7%. So 3%, 5%, and your 7% concentrations. Obviously, you have normal saline, but that's not hypertonic. But the advantage of hypertonic saline is you have a bunch of this. We talked about this mucus layer, the sol and the gel layer, right? That mucus blanket. What happens here is we're pulling from the lamina propria. Any water or salt, right? We're adding a bunch of salt. So I'm just going to do plus signs. Here we go. Let's do plus signs. We're adding a bunch of cations. We're adding a bunch of salt to the middle of the airway, to the mucus layer there, if you will. So if we add a bunch of sodium to the mucus layer, to the mucus blanket, it's naturally going to pull water, right? Water always follows salt. So via osmosis, it's going to hydrate that sol and gel layer. It's going to hydrate that sol and gel layer when we do hypertonic saline. So if it hydrates it, it's going to allow it to be less sticky. It's going to allow it to be able to be mobilized more effectively. So traditionally, your 3% hypertonic saline is used in pediatrics and to help thin out secretions. 5% can also be used in pediatric patients. 7% can also be used in cystic fibrosis. And then there's a 10% concentration as well. But the 10% is more designed to induce a cough so we can get a sputum sample. But the big understanding here is for sputum induction, right? You have to be aware because it can cause a bronchospasm. So be careful, right? You might have to pre-treat. Always follow your hospital's policy and procedure here. And then make sure you evaluate. If you give this to a patient and you didn't pre-treat them and they start wheezing afterwards, you might have to get an order or give them a bronchodilating medicine because that osmotic shift can cause a bronchospasm. So be careful with this medication, but it is a very highly effective way of doing it just by using osmosis to hydrate those secretions, allowing them to unstick. All right, are there other things that we can do besides giving them medications? Of course there is, and you've seen some of them on that last slide. You can use airway clearance therapy adjuncts like vest therapy, IPV, Medaneb, right? There's other things that we can do besides pharmacological interventions. CPEP is another one. So there, autogenic drainage, huff coughing, those things can really help with this as well. So there are a lot of other ways to help with mucus clearance besides the pharmacological route, right? And so don't neglect and think that we can just do it with pharmacology only. Are there other things that we can do that could enhance that? Absolutely. So what are things that we should assess when we're doing this, right? One of the things that we should assess here is the short-term usage of this. So short-term versus long-term, we need to make sure that these patients and their families are educated. They understand the adverse effects like the laryngitis, pharyngitis, right? Those types of things. They need to understand the reactions that the patient can have. In the long term, we need to look at things like their pulmonary function test values. Are their flow rates decreasing? Are they still decreasing at the same rate? Are they decreasing at a much slower rate? Right? Those are things that will be very helpful to understand if we're doing the right regimen or if it's not working. The other things that we're going to evaluate on the long term is if they have less exacerbations or less days that they miss school or less days that they're sick, right? So how often are they getting exacerbations? How often are they getting hospitalized? How often, so on and so forth. Those are things that are going to be helpful to see if these are long-term beneficial therapies for this patient. Now we're on to antimicrobial. So take some time, take a break if you need to. But antimicrobials is a whole separate section. Go ahead and make sure that you're summarizing the mucolytics, mucoactive medications, when you would use them, when you wouldn't, what you would do with education, things like that, and before moving on, so that way you have everything categorized and ready to go. All right, antimicrobials. The first one that we'll talk about here is going to be a medication called pentamidine, also known as Nebupent or pentamidine. Pentamidine is a medication that I've given multiple times before in our pulmonary function lab. So this is a medication that's a prophylactic. It's a preventative for pneumocystis carinii or pneumocystis jirovecii is what it's now called, which is PJP. But it's also known as PCP, or also formerly known as PCP. Pneumocystis carinii was PCP, but now it's called pneumocystis jirovecii, right? And this is to prevent that pneumocystis in high-risk HIV or immunocompromised patients. So when we're looking at this, the history, patients that have a history of one or more episodes of PJP, that's where this medication can come in and help out. It's mainly for T helper cell counts that are super low. So if their T cell count is low, that's where the pentamidine or Nebupent can come into play. In this one, you will see that we nebulize, and we nebulize in what's called a Respigard 2 nebulizer. We do have to check the patient's blood pressure. We have to usually put them in a negative isolation room. We do have to wear a gown and goggles because it can be very irritating. So this one's a whole different thing. It usually comes in a powder that we then have to mix with saline to then nebulize for these patients. And usually that Respigard 2, you have to run it around 7 liters per minute. So if you have to do this, hopefully you remember that I told you about it, and you'll remember what video to go back to. The mode of action for pentamidine is not understood very well, similar to the mode of action for xanthines, right? Remember xanthines? But the mode of action for pentamidine seems to interfere with the nuclear metabolism, and it inhibits that DNA, RNA, phospholipids, and protein synthesis, so it should help slow down. It's a prophylactic for the PJP. When we give it, it's nebulized, right? It's usually nebulized, and that's where I talked about that being a Respigard 2 nebulizer. And it really is not absorbed if it's given orally, so that's why it's also available in IV and IM formulations, but nebulized is usually a little bit less invasive. If you come in once every 3 to 6 months to the PFT lab and I can nebulize this to you compared to getting an IV or IM shot, that could be a lot more beneficial. So Nebupent, like I said here, aerosolized or nebulized pentamidine is prophylactic, and we can still use it in acute episodes. So if someone comes into the hospital with a PJP pneumonia, you could still nebulize pentamidine or Nebupent to that patient. The dosage here would be 300 milligrams once every 4 weeks. So we can nebulize it still in the hospital, but primarily you're going to see this as a preventative in your outpatient area. Like I said, in our PFT lab, they would come in and schedule that, and we would do it there. This one, the advantage of it being nebulized, just like other nebulized medications, is it's technically topical, and it will have a local effects versus systemic side effects. So a lot less systemic side effects when we nebulize it. A little bit about the Respigard 2 nebulizer here. It has one-way valves and an expiratory filter. So hopefully you, being in the room with this patient, don't get exposed too much with it. You're going to have that expiratory filter, and then like I said, our policy was to run it around 7 liters a minute. Your hospital policy and procedure might say somewhere in that range. So it could be done in a negative pressure room, which is what our policy was when I was giving this. Some hospitals will actually make you pre-treat with a beta agonist, so they'll make you do a bronchodilator beforehand, right? An albuterol or something of that nature, because this can cause effects and it could cause a bronchospasm with how it runs, because it can be that thicker powder, more aerosolized medication, a lot less fine, a lot larger, more irritating particles, if you will. Why did we do a negative pressure room? Well, the effects will decrease, right? The systemic effects will, not systemic, but the effects on the providers and everybody in the room will decrease in negative pressure rooms. So if they have a hood or a tent or something like that, when we do this, we have the patient turn off the nebulizer if the patient's going to remove it from their mouth, because we want to avoid it from getting into their room. So what does it look like? Well, here's the picture of what the Respigard 2 nebulizer looks like. This would be a picture of one. There's better pictures out there, but here the patient will breathe through this mouthpiece, and then obviously it's nebulizing. Here it has this one-way valve, so they can entrain air in here, so that air that they're pulling in will mix with the pentamidine, right? And they're breathing it into their mouth, and then when they exhale, it goes over here past this one-way valve into this expiratory filter that helps prevent it from going into the rest of the room. So they can pull air in and get the medication in, and then they exhale it through that. So it's just setting up a one-way circuit. Systemic side effects of pentamidine can include pain, swelling, abscess formations if it's given IV. So that's why you see, hey, nebulized, not a bad idea in theory. It can cause thrombophlebitis and issues with given IV. We can even see things like hyperglycemia. That inflammation that they can get from this can cause blood clots to form, and that's where we see that. But we can also see it when it's given systemically, right? The key word here, let me use red, right? Systemically. This is systemic, not aerosolized, right? Systemic. So IMRIV is where we're going to see all these side effects. Hypoglycemia, impaired kidney function, hypotension. That's why we'd still, even nebulizing it, check their blood pressures every couple of minutes. I think it was every 5 minutes we cycled that cuff. Leukopenia, and then even hepatic dysfunction, liver dysfunction, right? So that's a lot of stuff that you have to watch out for systemic, right? Once again, the key thing here is systemic side effects, but even like I said, we would use blood pressure, we'd still look out for systemic side effects. Even when nebulizing it, just because you're nebulizing it doesn't mean that patient couldn't have systemic side effects. All right, here are the ones for aerosolized side effects. Aerosolized side effects includes a cough, bronchial irritation, and that's where we see that with the bronchospasms and wheezing too. If they have irritation, it can cause that bronchospasm and wheeze. So that's when you might pre-treat, depends on the hospital's policy and procedure, or you might have to be prepared to give them a bronchodilator after that you're done with it. They can become short of breath. It can taste not so great. I don't remember the taste at all, but I tried to, we did the negative pressure room and all the other precautions. So I guess that was pretty good if I didn't know what the taste was. Spontaneous pneumos can be a factor. Conjunctivitis, right, in the eyes, especially if it's nebulized. That's why the negative pressure room could be very helpful as well. Rashes, neutropenia, pancreatitis, right? These are aerosolized side effects, right? You can even see things like renal insufficiency, hypoglycemia, so be careful there. And then necrosis of the fingers, right? Digital necrosis. And then the other thing here to pay attention to, I didn't have to worry about it too much for myself, but pregnant nursing women should avoid giving these treatments, right? That's not something that's good for them. All right, that was a lot of stuff about Nebupent or pentamidine. So understand your side effects, understand what patient population, how it's usually used as a prophylactic for T cells less than 200, T cell counts that are low. And then we can nebulize it, 300 milligram dose. We want to make sure that we understand the precautions, who can give it nebulized, and then what other forms it comes in with IV and IM, and then side effects systemic versus side effects inhaled. So those are the things you want to go over there. The next one that we'll talk about is ribavirin. Ribavirin. So new drug, ribavirin. It's not a new drug. We're just talking about a new drug, right? Next drug. This one is not considered virucidal. It's not considered virucidal. It does not destroy the virus. But what it's used for is the treatments of infants with severe RSV, not just your mild RSV, but severe respiratory syncytial virus. And it is classified as an antiviral drug, but remember, it does not kill the virus. It's not virucidal. The mode of action is actually what's called virostatic. I'll circle it here. Virostatic, which means it's going to stop it from replicating. It's going to stop it from producing more. And so when it does this by inhibiting both the DNA and RNA part of it. So when we're looking at RSV, that's the primary cause of bronchiolitis in those little babies, right? Primary cause of bronchiolitis in those babies. So it doesn't kill the virus, but it helps stop it from replicating, and that might help them gain better control or be enough to help reduce the severity of their disease process. So this is for severe. Like I said, severe is the key word there. Severe RSV. So it's not for routine use infections. RSV can be very life-threatening in cases, especially if these babies have a history of prematurity. There's another drug they get called Synagis. It's a shot they get in their muscle. All right, it's an IM shot. They get it once a month. If they're preterm, they can qualify for it, usually just during respiratory season. A very expensive medication, but that can also help prevent them from getting RSV. So that's more of an immunization. This is a nebulized medication if they already have it to help stop replication. So RSV can be very life-threatening, like I said, especially in compromised babies, such as babies that have been premature or other issues there. The big issue that you have to also worry about here is the risk of exposure of the drug to personnel. And the patient, when they're on this, is to be placed in a contact or airborne isolation. And I'm pretty sure this one is just the same as pentamidine, where you don't want people that are pregnant or breastfeeding to be exposed to this medication. The dosage is going to be that 20 milligram per ml solution. It's going to be given by the SPAG2, small particle aerosolizing generator nebulizing, right? Small particle aerosolized generating nebulizer. And this is done 12 hours. 12 hours. So when we're looking at this, it's a minimum of 3 days when we're doing this, where we're trying to stop it from replicating. But usually they won't let it go past 7 days. They won't let it go past 7 days. The big thing here is making sure that that they give us that. Some pharmacies will mix it for us. However, they can give you that 6-gram dry powder in 100 mLs, which would reconstitute with sterile water, so you can mix it as well. But if pharmacy will mix it for you, all the better. Here's your picture of the SPAG, the small particle aerosolizing generator. This one, and you may see this at your clinical rotations. We have some of these at the campus as well, or one of these at the campus. But these are large volume nebulizers, and there's a very big tank, right? Look at this 500 ml reservoir here, right? And the solutions in the reservoir should be replaced every 24 hours to help avoid that drug from reconstituting or settling in there. And so this you can run in line with mechanical ventilation. You can run spontaneously as well. So make sure you follow your regulators and you understand when you're going to use a spag, what drug you would use a spag with, and the components of the spag. Those are all things they could easily ask you about on your board exams as well. Side effects of ribavirin. The big one is going to be pulmonary deterioration or pulmonary function. So we got to worry about this, especially for kids that have reactive airways. They can make their asthma worse or the COPD worse, right? So we got to be careful because it can be very irritating to their airways. Even things like pneumo, we can see it inhibit their ability to breathe. They can develop bacterial pneumonias, because what happens when we're doing this, we're stopping the replication, and so now their system is more prone to other things, including bacterial pneumonias. Pretty significant. They can also undergo cardiac instability, so hypotension, they can go into cardiac arrest, digitalis toxicity, right? So this can be a big thing for those patients. And this is just the pulmonary, right? Pulmonary and cardiac. There's more. The more is the dermatological, right? They can have a rash, red eyelids, conjunctivitis, right? So there's the skin irritation as well. So understand as you're doing this or giving this to a patient, it can clog that expiratory sensor and clog those expiratory filters. So if you have some sort of HEPA filter on your ventilator on the expiratory side, it can clog those. So that patient might be working hard to exhale. Hey, check that expiratory filter, right? Or the sensors could go wrong, so you might have to take them out and clean them. And then even in some patients, some endotracheal tube blockages can occur as well and make it hard, obviously, for them to breathe. So you got to be very, very cognizant of how you're giving this. And even with this, if you're giving it in line with the ventilator, traditionally you have to add a column of water above what the patient is getting to avoid the loss of pressure with it. So there's a whole separate protocol for places that use this. There's usually a whole separate protocol or setup of how to use it in line with mechanical ventilation, which hopefully you'll talk about that at one point in a class as well. The last part here, I'm glad I remembered it. Once again, pregnant women should not be given the treatment or be exposed to it. So once again, not something I had to worry about, but it might be something you and your loved ones might have to worry about. So be aware of that as well. Moving on to tobramycin or Toby, the big indication for this one is management for control in chronic acute Pseudomonas in cystic fibrosis. Pseudomonas in cystic fibrosis. Pseudomonas in cystic fibrosis. Now I have given this for non-cystic fibrosis bronchiectasis that had Pseudomonas, so I have given it outside of that label before, but your primary indication is for the label of Pseudomonas in cystic fibrosis. So we get a sputum sample or trach aspirate and it grows Pseudomonas. There you go. That's tobramycin. That's the medication for them. And it's been shown to improve pulmonary function. And then chronically, it helps reduce the need for IV antibiotics, which is great, especially for things like your GI bacteria. Do you want to destroy your GI bacteria every time you take an antibiotic? No, the GI bacteria is good stuff, right? And so the advantage with nebulizing tobramycin is we don't have to destroy all that good bacteria that your body also has, right? So reducing the need for IV antibiotics and hospitalization, that's a big, big bonus. The dosage. So when we're looking at this is something to put on your drug table. The dosage is 300 milligrams twice a day, a little BID action there, for 28 days. And you're trying to do it consecutively for 28 days, and then you'll do 28 days off. So they cycle. They cycle on and off with this situation. The 300 milligram is going to come in a 5 ml ampule. So when we're doing this, we're going to traditionally use the parineb, right? The parineb. Do not mix with Dornase alpha, right? There is a chemical reaction there. This one should be refrigerated. And then this one, you want to make sure anti-infective agents. Remember, we talked about this in other lectures already, but when you're doing the order of operations for nebulizing, they like to ask this on the board, so pay attention. The order of operations would traditionally be a bronchodilator. Then you're going to do your long-acting medications. Then you're going to do your inhaled corticosteroids. Inhaled corticosteroids are always last, unless they're on an inhaled anti-infective agent. So the anti-infective agent actually will trump the inhaled corticosteroid. So that's when the anti-infective agent will go last. But the big thing here, what if they're also getting airway clearance therapy? Well, evidence shows that during a vest therapy that there's better particle deposition in the airways. However, this medication should be given when the airways are already as clear and as open as possible. So you'd give this after a vest therapy. Once again, after a vest therapy. This medication really does taste bad, so you got to be prepared for that. The patients may not be excited every time you go in there with that medication. And the solution, if you see it's dark, it gets dark because it's not refrigerated. So this one needs to be kept in the refrigerator as well. So the mode of action, it blocks the protein synthesis in the bacteria that causes the cellular death. The big precaution here is going to understand that inner ear, that sense of balance. It can really make it hard for their vestibular and neuromotor dysfunction. So balance and movement can be very difficult for them. They can develop resistance to organisms as well. It can cause fetal harm. Airway irritation, as with anything, it can cause an allergic reaction. So this is another one that we have to be very careful. A lot of side effects, can be a very dynamic medication. When it's given IV, it can cause things like ototoxicity, right, with their ears. We already talked about the vestibular and neuromuscular dysfunction that it can happen, that sense of balance. They can have a hard time there. Nephrotoxicity, their kidneys. It can have issues where, like I said there, neuromuscular dysfunction, so that neuromuscular blockade effect. Hypomagnesia, right, and fetal harm, even deafness that can really occur there when given that route. But however, now we're looking at something like aerosolized. Aerosolized is going to be a little bit different. With aerosolized, we can get things like tinnitus, which should still be in the ear, that high-pitched ringing, and some voice alteration. All right, if you had to pick between these two, which one would you pick, right? Which one would you pick, right? So hopefully you sort of see that advantage of aerosolizing it versus giving it systemically. Casein, I've nebulized this drug before. The big indication here is to improve symptoms in cystic fibrosis patients with Pseudomonas. Right? Once again, Pseudomonas rears its head primarily for cystic fibrosis patients. It's not for children that are smaller, but the big mode of action is it will bind to penicillin, binding proteins of the pathogen, which then inhibits the bacterial cell wall synthesis and ultimately will kill the cell. It kills it. But the big one here with casein is you need to make sure that you pre-treat with a beta-2. You really need a beta-2 to pre-treat with this one. It can cause bronchospasm. So traditionally, they'll give you a PRN order for bronchodilator and use it, right? Use it before you give this medication to those patients. The dosage, 75 milligrams in a 2 ml glass vial, and you got to mix it with sterile saline. You got to mix it with some sterile saline, and it will come in a 28-day kit for these patients. So you have to teach the parents or whoever how to do it as well if they're not going to stay in the hospital the whole time. You're going to use what's called an Altura nebulizer system. There are 3 times a week. They'll do 28 days on, 28 days off. With this, and it can cause bronchospasm. So make sure that you inform whoever's giving it that pre-treatment is going to be a key, or making sure you can reverse a bronchospasm is something that's readily available. This medication also should be refrigerated. Do not shake this one. This is not a medication that you want to shake or mix up by shaking. Zanamivir, this is another one, or Relenza is the other name for it. Let's just call it Relenza. Relenza disc inhaler, so you'll see they're out there. The indication for this one is influenza in adults, right? So influenza in adults and children 5 years and over who have been symptomatic for no more than 2 days. We got to do it in under 3 days. It is off-label in treatment of any type of flu, like the swine flu. It was off-label and they were using it. But the big thing, this one's got to be done early on in the flu process to help reduce those side effects and to help reduce the potential or the severity of the flu. It does work by inhibiting the viral enzyme causing viral aggregation to the cell and each other. So they try to stop the viral enzyme, right? They try to stop that viral enzyme from replicating. So the whole idea is to help reduce it, the severity of the flu, not to stop it altogether. The dosage, it can be given as a dry powder inhaler. They're little 5 milligram blisters. Once again, adults and children over 5, and they can do twice a day for 5 days. The big side effect is going to be bronchospasm. Under the treatment of bronchial infections, they can have allergic reactions. Under treatment, bronchial infections can be one of those things we have to be concerned about, but it's not generally recommended for patients with underlying airway disease, right? This route is not great for patients that already have airway issues to begin with. And it's not approved for prophylaxis. It's only if they have tested positive for influenza and it's been less than 3 days. So when we're looking at this one, all inhaled antibiotics, we need to look at what happens long-term with them. What are their PFT studies showing? Is it toxic to their airways? Are they getting better? Are we educating the patients on the side effects? Are we looking for things like drug tolerance? Are we looking at their labs to see where their things like their cell counts are if we're looking at NebuPen, right? So we have to be looking on all inhaled antibiotics. We have to be looking at all the different things that can help us understand what's going on and if the patient is benefiting from it or possibly getting worse. General contraindications for pentamidine would be bronchospasm and cough. So if someone's already in a current bronchospasm and they're having a hard time not coughing, this patient is not traditionally healthy enough for this medication. They're going to lose a lot of it if they're coughing through the whole treatment. If they have bronchospasm, are they going to get good particle deposition into their airways? No. So that's where that comes into play. For ribavirin, pregnant caregivers really do need to avoid exposure. Tobramycin, the big thing we have to worry about that is building up drug resistance. And then zanamivir, the big thing would be pre-existing airway conditions. Could be a big contraindication because if they already have obstructive flow rates, if they already have issues, then this is not the medication that's going to help them be effective for them because they already have issues with getting medications deposition into their lung. So let's move on to vaccines. So Synagis, I mentioned this earlier when we were talking about ribavirin for RSV. The Synagis is the one that I like. My daughter was on this one for a while, and it helps prevent the serious lower respiratory tract disease caused by RSV in high-risk infants and children. So kids that have poor immune systems, premature kids, things like that. That's going to be very helpful in them. Like I said, it's an IM administration. It's given IM. It's a shot. It's once a month during respiratory season. And it really does help decrease the risk of death from RSV. So it doesn't prevent them from getting RSV, but if they do get it, it should help them reduce their risk of death from it for those patients. Big side effect, and this one, I can attest to this personally. Whoever's giving it, there's epinephrine that actually comes with it. So that way, if they go into anaphylaxis, they can give it right away. So it can be given at home by a home care nurse, right? But they're provided with epinephrine, so that way if something were to happen, they could reverse the anaphylaxis, or at least start reversing the anaphylaxis right away. Other things that can happen with this drug: fever, upper respiratory infections, rhinitis, pain, rash, especially on these patients, hernias, coughing and wheezing would be another one. And those ones are more traditionally associated with that anaphylaxis reaction to it. So that's going to be that one for pediatrics or newborns anyway, you're going to see out there. The other thing that you need to pay attention to is the regular flu shots, the regular immunizations for people that have airway issues like COPD, asthma, emphysema. So the flu shots, the annual flu shots, and the vaccinations are very helpful. Once again, they don't prevent you from getting the disease. It just helps reduce the severity of the disease. And then the other one that I want you to be aware of is for patients, I believe it's older than 65, is getting the pneumonia vaccine. There's a pneumonia vaccine for a very common strain of pneumonia out there, and that should help patients, especially that have compromised immune systems or compromised airways, to help reduce the severity of that pneumonia if they were to get it. And that one, I think they only get every 5 years or so. But that's something else to be aware of with your patient education to help prevent these people that have chronic respiratory issues, neonate through adults, help them have better quality of life, to help them be more likely to survive their exacerbations as well.